Hello everyone, I'm Wu Meichong from Fujian Provincial Hospital of Fujian Medical University. Today, we are going to talk about auscultation of heart. Cardiac auscultation is one of the most important and difficult parts of cardiac physical examination. When we are doing cardiac auscultation, we need to pay attention to the following 5 aspects. Which area should we auscultate? What's the heart rate? Whether the rhythm is regular? Is the heart sound normal? Do you hear the cardiac murmur? There are some certain locations on the patient's thorax or chest that you can hear heart sounds with your stethoscope clearly. Please look at the picture. It shows the auscultatory valve area, including the aortic area, the pulmonary area, the second aortic area, the tricuspid area, and the mitral area. The picture in the left shows the mitral area, which is located in the apex beat. The picture in the right shows the pulmonary area, which is located in the second intercostal space and the left external border. Similarly, these pictures show the aortic area and the second aortic area. The second aortic area is also called up area. Last one, the tricuspid area located in the lower left sternal border. After studying the auscultation area, let's learn about the contents of auscultation. When we perform auscultation in above auscultation areas, we should pay attention to the heart rate, rhythm, heart sound, extra sounds, cardiac murmurs, and pericardial friction sound. Heart rate means the number of the heartbeats per minute, usually heard at the apex. In normal adults, 60 to 100 beats per minute is considered as a normal heart rate. More than 100 beats per minute is called tachycardia, and less than 60 beats per minute is called bradycardia. Tachycardia and bradycardia can be caused by following factors. Physiological, for example, physical activity may cause physiological tachycardia, and athletes may have physiological bradycardia. Pathological, for instance, fever, anemia, hyperthyroidism can cause pathological tachycardia, and thyroid hyperfunction may lead to pathological bradycardia. Next, we should make sure if the rhythm is regular or irregular. For example, a regular rhythm is consistent with sinus rhythm, sinus tachycardia, sinus bradycardia, atrial or nodal tachycardia, atrial flutter with a regular ventricular response, ventricular tachycardia, atrial ventricular block, and so on. However, an irregular rhythm is often seen in sinus arrhythmia, premature beats, atrial fibrillation, and atrial flutter with varying block. In clinic practice, the most common arrhythmias are premature beats and atrial fibrillation. Premature beat is a sudden heart extrasystole in a period of regular heartbeats and then followed by a longer compensatory pause. If premature beats appears regularly, they could be named bigeminal beats or trigeminal, and so on. The bigeminal beat refers to every sinus beat is followed by a premature beat continuously. Similarly, the trigeminal means every 2 sinus beats is followed by a premature beat continuously. Here is an audio about bigeminal beats for your reference. As for atrial fibrillation, there are three characteristics like following: irregular rhythm, variable intensity of first heart sound, heart rate is greater than pulse rate. Here is an audio about atrial fibrillation for your reference. After learning the cardiac rate and rhythm, we will discuss heart sounds, which includes the first heart sounds, S1, caused by the closure of atrioventricular valves. The second heart sound, S2, caused by the closure of semilunar valves. The third heart sound and the fourth heart sound. The normal S1 is mainly produced by vibration generated by the closure of mitral and tricuspid valves, which marks the beginning of the ventricular contraction. The S1 is normally loudest at the apex. The normal S2 is mainly produced by the vibration generated by the closure of the aortic and pulmonary valves, which marks the beginning of the diastole. The S2 is heard best at the bottom of the heart. Normally, closure of the mitral valves is slightly earlier than the tricuspid valve, and aortic closure precedes pulmonary valve closure. But this distinction is hard to be heard. However, it could be detected by auscultation under some conditions, which defines as sleeping of heart sounds. A sleep S1 is usually heard in the setting of a right bundle branch block. Because in RBBB, the electrical impulse reaches the left ventricle earlier than the right ventricle, resulting in mitral and tricuspid valves to close at different times. Let's listen to the audio about splitting of S1. The sleep S2 can normally be heard during deep inspiration, which is called physiologic splitting. In addition, the sleep S2 can be heard in pathology, such as atrial septal defect, mitral insufficiency, pulmonary stenosis, and so on. Let's listen to an audio about splitting of S2. Sometimes we can hear the third heart sound and the fourth heart sound. The S3 can be heard in both normal and abnormal situations, whereas if the S4 sound be heard, it indicates a sign of a pathological situation. In most cases, only S1 and S2 sounds could be heard. Therefore, it is essential to identify the S1 and S2. This table will help you identify S1 and S2. Generally, the S1 is low-pitched, loud intensity, and long-lasting. Besides, it occurs simultaneously with the apex beat and can be heard best at the apex. On the contrary, the S2 is higher and sharper in pitch as well as lower in intensity and shorter in time than S1. Besides, it does not occur simultaneously with the apex beat and can be heard best at the bottom of the heart. Here is the audio about the normal heart sound for your reference. In addition, there are many factors that affect the intensity of heart sound, such as lung, chest wall, thoracic cavity, and so on. However, myocardial contraction, valve position, valve structure, valve elasticity play a most important role among all factors. Next, we'll talk about the extracardiac sound, which is pathologic and mostly occurs after S2, called diastolic extracardiac sound. If it occurs after S1, it is called systolic extracardiac sound. The diastolic extracardiac sound includes the following contents: gallop rhythm, a sign of serious myocardial damage; opening snap, pericardial knot, tumor plop. As for cardiac murmurs, it is the abnormal heart sound heard in systole or diastole, besides the normal heart sound and the extra heart sound. This slide shows the mechanism of the heart murmurs. In normal vessels and heart chambers, blood flow presents a laminar flow that cannot produce the sounds. However, when the blood flow accelerates or gets through narrow valves, laminar flow tends to be turbulent flow or vortices. Turbulent flow or vortices vibrate the heart wall, vascular wall, valve, and then the relative murmurs are generated at the corresponding location. When the cardiac murmurs is heard, you should differentiate it belongs to systole or diastole. Firstly, just like the extracardiac sound, the murmurs occur after S1 is called systolic murmurs. If it occurs after S2, it is called diastolic murmurs. When the murmurs occur in both systole or diastole, it is called continuous murmurs. This radio might help you identify them.
As you move your stethoscope across the precordium, the first thing you'll want to do is differentiate between systole and diastole. As you first start out, this might be a difficult skill to learn, but this is easily accomplished by palpating the right carotid pulse as you auscultate and comparing this with the sounds you hear with your stethoscope. As you palpate the carotid pulse, remember that each carotid upstroke coincides with one cardiac cycle, and therefore also one systole-diastole cycle. The first sound you hear before the carotid upstroke is S1, and the sound following the carotid upstroke is the S2. Let's slow this down a bit. You'll want to time each carotid upstroke or pulse to each sound you hear. The sound you hear before the carotid upstroke is S1, and the sound you hear after is S2. For experienced providers, this might not be very difficult or even necessary for simple sounds. However, for those of you new to auscultation, figuring out when systole and diastole occur is an absolute prerequisite before you start identifying murmurs and extra heart sounds. Take this sound for example. You hear the rhythmic alternating of sounds, but which is S1 and S2? If you were to palpate the carotid and feel an upstroke here, then you would label this S1, since it's before the upstroke, and this S2, given it is after the upstroke. In this sound there's a murmur, but is it systolic or diastolic? By identifying S1 and S2, you can narrow the murmur as either being systolic or diastolic, and from there narrow your differential diagnoses as to what might be causing the murmur. In this case, the carotid upstroke is felt here, then this would be S1, and this S2, making this a diastolic murmur.
Next, the area with the loudest murmur could be identified. Usually, the murmurs are best heard over the diseased area. For example, if the murmurs are best heard at the apex, It always represents that the disease region is mitral valve. In addition, when listening to the murmurs, we should also pay attention to the quality, intensity, form, conducting direction, and the impacts of body position, respiration, and exercise. The murmur plays an important role in the treatment and the diagnosis of heart disease. Generally, murmurs can be classified as physiological murmurs and pathological murmurs according to the clinical significance. The table shows how to differentiate between physiological and pathological murmurs. Compared with the pathological murmurs, physiological murmurs are usually harmless. It is systolic, soft, blowing without a thrill. The murmurs occur after S1 is called systolic murmurs. This table shows the feature of pathological murmurs in systole. The murmurs occur after S2 is called diastolic murmurs. This table shows the feature of pathological murmurs in diastole. In the aortic area, the organic murmurs usually occur in aortic stenosis with various causes. It is mid-systolic, jet-like, loud, harsh, and crescendo, decrescendo. It conducts towards the neck and always presents with thrill and decreased A2. Here is a video about aortic stenosis for your reference. In a patient with rheumatic mitral stenosis, an organic murmur will be heard. It is a mild or late diastolic, low-pitched, rumbling, and a crescendo murmur with loud S1 and a thrill. It is limited at the apex of heart and can be heard more clearly if the patient lies in supine or lateral position. Let's listen to murmur of mitral stenosis together. The continuous murmurs usually occurs in patients with ductus arteriosus, and it results from blood flowing continuous into the pulmonary artery during the entire heart cycle. This murmur, which persists from systole to diastole, ever covering the S2, is harsh and machine-like, and it best heard at second intercostal space, left to the sternal border and usually with thrill. In addition, there are two special murmurs, the Austin-Flint murmur and the Graham-Steele murmur. In moderate or severe aortic valve insufficiency, the increase of left ventricular diastolic filling makes the mitral valve in a half-closed state, which generates a murmur called Austin-Flint murmur. Compared with organic mitral stenosis murmur, it is usually soft, decrescendo, and without thrill. Graham-Steele murmur is a functional murmur produced by relative pulmonary insufficiency, which is caused by dilatation of pulmonary artery. It is usually soft, limited, decrescendo, diastolic, blowing, and compared with increased P2.
When you're just starting to learn how to auscultate, you might be wondering where you should place your stethoscope. Additionally, you might be wondering where to move your stethoscope next, after you first place it on your listening surface. These are both important questions, but luckily the answer is simple. You could start either at the base of the heart and work your way towards the apex, or you could start at the apex and work your way towards the base. So starting at the apex, you would move your stethoscope medially towards the left lower sternal border, then upwards towards the left second intercostal space, and then across to the right second intercostal space. You could also do this in the opposite direction if you'd like, starting at the right second intercostal space, then across to the left second intercostal space, next down to the left lower sternal border, and finally to the apex, while pausing and listening carefully at each auscultation point for normal and any abnormal sounds. As you listen at each point, keep in mind that some sounds are best heard better than others at different points. For example, a normal S1 and S2 have different sound intensities when listening for them at the base, compared to the apex. Classically, S1 is usually louder than S2 at the apex, and S2 is usually louder than S1 at the base. Specific murmurs also have locations on the chest where they're heard loudest. Take the murmur of mitral stenosis, for instance. It is best heard at the apex. Aortic stenosis, on the other hand, can be heard throughout the precordium, but loudest at the base, with a murmur radiating towards the neck and axilla. Heart sounds and murmurs will often have an area of maximal intensity and radiation across the chest, but we'll leave that for another video in the series. For now, just remember that when listening to heart sounds, start at one end of the precordium and inch your stethoscope towards the other side, noting what you hear at each auscultation point. You could learn more about these sounds and interact with them at auscultate.medschool.com, which is our interactive web application and medical sound library. You can navigate through each auscultation spot to expose the sounds you might hear at each area. You could also explore each sound further for deeper dives into each sound for things like sound variations, pathophysiology, and much more.
Okay, that's all for today's class. We have discussed about auscultation of heart. And here is a video for you to review today's lesson. Thank you for your attention.